Hello everyone, hope everyone is in good health. So for this topic, I decided to break away from convention. Macular hole as such is not a very commonly asked examination question in terms of university theory and practical examinations, but very often we find that in NEET PG, because it is one of the neglected topics in undergraduation, NEET PG shows a tendency to pick up such topics. So that's the only reason why I thought I should deal with this once, and just to break the monotony of the common topics that we utilize, we'll deal with macular hole today. So macular hole is exactly what it is. There is a hole at the macular region, at the fovea, where there is an absence of neural tissue. So what causes this hole? First of all, we do not know. Most cases, more than 70% cases, are idiopathic. The other less common causes are blunt trauma. So the incidence of blunt trauma is higher as compared to being diagnosed as an idiopathic case. So sometimes blunt trauma and idiopathic are considered to be equivalent, but idiopathic is the more common variety. Post-surgical, which means after a rhegmatogenous retinal detachment surgery or after performing vitrectomy, you can induce a macular hole. And lastly, if the patient is high myopic. So high myopic means the eyeball has an abnormally long axial length most commonly. So because axial myopia is the most common type of myopia, so that makes it easier for the macula to undergo a degeneration and develop a hole. So let's look at certain facts and figures. 1 in 500 patients with ocular complaints are going to present with a macular hole. So one of the rarer diseases in ophthalmology. Also, it occurs between 6th and 7th decades, so less commonly encountered in a regular clinical practice, because such patients usually do not come to us with retinal complaints. This age group will most commonly come to us with cataract, and macular hole may not be looked for or diagnosed in such patients because you're primarily dealing with the cataract, and the opacity is going to make it difficult to look at the retina. So female to male ratio is 2:1, and 10 to 20% cases are bilateral eventually, but rarely are both eyes affected at the same time. And fellow eye is involved within 5 years in about 10% of the patients. So what exactly goes wrong in a macular hole? There are abnormal tractional forces of the vitreous on the macula. So what do I mean by this? Macular hole is not exactly, the macula is not at fault in a macular hole. It is the vitreous which is at fault. The vitreous, if you remember, is a jelly. It is not a liquid. And in that jelly, there are fibers, there are strands, strand-like material that is present. It's protein after all, so there's going to be strands. So those strands exert a tractional force at the macula. So why at the macula? We still do not know. That is why the most common cause is also idiopathic. We still do not understand why exactly and how exactly it happens. It's a relatively, a recently studied disease. It started gaining prominence after the 1990s when surgical management started becoming more prominent. But anyway, coming back to the topic, abnormal tractional forces are occurring at the macula. And how do we know this? We know this because some surgeon in the past decided to operate on the vitreous and see if the condition improves. So vitrectomy was performed, the vitreous was removed, and it was seen that the patient's condition improved. The symptoms, the signs, everything started getting better. So this evidence came from vitreous surgery, which turned out to be successful. And if there is no traction, then there is just a shrinkage of the vitreous cortex. Remember that this is happening in an age group of 60 to 70 years old individuals. So naturally there is going to be some degeneration throughout the body. So the vitreous is no different. The vitreous is going to undergo a focal shrinkage, and if this focal shrinkage happens at the fovea, so that shrinkage is going to exert a pull on the macula, and that is how the hole is going to develop. So the ultimate thing that happens is that the photoreceptors are lost, which means the rods and cones are lost, but the retinal pigment epithelium layer, the outermost layer of the retina, that's going to remain normal. That's going to remain in position. So it is a loss of all the layers inside, above, or lying before the RPE that are lost, the other 9 layers that are lost. So that's how a macular hole develops. So what clinical features are you going to see? The first symptom is metamorphopsia. So what do I mean by metamorphopsia? There is an alteration in the shape of the object that the patient is seeing. So notice image A, which is a normal grid of vertical and horizontal lines. The same image which is being perceived by a patient of macular hole is going to show some distortion. It is going to appear distorted. So very often, in the usual life, the routine life, the patient is going to say that there is a blurring of the image that I'm trying to see. I'm not able to distinctly see it clearly. And this often goes undetected in unilateral cases because, bilateral vision more or less compensates for this blurring. So if the left eye has a macular hole, and since the condition is not affecting both eyes at the same time in most cases, it is unilateral in most cases at a time, the other eye is going to compensate for that blurring, and the patient is going to be able to perceive that spot of vision very clearly. So it often goes undetected unless you perform specific uniocular investigations. So there is basically a foveolar dehiscence, which means at the fovea, this fovea is at the center of the fovea, which is at the center of the macula. So the centralmost part of the retina where there is maximum visual acuity, that area shows a retinal breakage, a dehiscence, which is produced due to this traction. This vitreous produces a traction, pulls away the overlying retina and leaves behind only the RPE layer, the retinal pigment epithelium layer. And this is made worse if there is a surrounding retinal detachment. It makes it easier for the traction to happen if there is already a coexisting retinal detachment. The second category of patients may be asymptomatic, and it might just be an incidental finding while operating for a rhegmatogenous retinal detachment. Because understand that in a rhegmatogenous RD, the patient is going to present to you with diminution of vision, and at this point you may not suspect a macular hole, but while operating intraoperatively, you may see that this patient has a macular hole as well, and that will require appropriate management on table. What signs am I going to see? Broadly, there are going to be cystic changes in the normal perifoveal retina, which means the fovea is of course damaged in a macular hole, but around the fovea as well, I could have cysts, I could have intraretinal or subretinal cystic changes because of an associated degeneration. An epiretinal membrane is very often seen, which means a membrane over the retina. So this membrane will be closer to the vitreous compared to the retina. And finally, rhegmatogenous retinal detachment, which could either be a coexisting finding, an incidental finding, or could cause the macular hole itself. And rhegmatogenous RD is especially common in cases of abnormal vitreous traction. So what do I mean by abnormal vitreous traction? It means that some amount of traction is present in elderlies because of the degeneration, but this abnormal vitreous traction means that there is no pattern that this traction follows. And high myopia, as I've already discussed, because of an elongated eyeball and a posterior staphyloma, which means there is a bulge in the eyeball posteriorly, it becomes easier to pull away the retina at the macular region. So this is how an epiretinal membrane looks like. This is an associated finding that is seen in macular hole. So the left-sided image is a black and white image. We call it a red free filter because everything that is supposed to be red appears black. So this is very often used for blood vessels, but it also shows that white, papery thin sort of a structure at the center, the whitish structure at the center. That is the epiretinal membrane. Compare that to the image on the right. It's the same eye, but now this is a regular lighting. There is no red free filter that you're using, so you're going to see the retina as is. So in this case, it becomes more difficult to see the epiretinal membrane. So how do I know in the right sided image that there is a membrane? You will see stretch marks across. So it's like a sort of a sellotape that is stretched across the macula and been pasted. So those stretch marks that you see, that is evidence of epiretinal membrane. So sort of indirect finding that you can see. So this is an OCT, an optical coherence tomography. This is nothing but B scan that is done of the retina. It's basically ultrasonography of the retina. So the red arrow points to the epiretinal membrane. This is an abnormal OCT because of two things. Firstly, the fovea is elevated over the surrounding retina. So the fovea is the the dome that you can see at the center. That is supposed to be depressed because fovea ideally has lesser number of retinal layers compared to the rest of the retina. It is predominantly made up of rods. However, this image shows that there is an elevation of the OCT and there is also an epiretinal membrane. Compare this with a normal OCT shown at the bottom of the shown in the bottom image. There is a pit, the foveal pit. So naturally the OCT has to dip down. Here the OCT is being elevated and there is a membrane that is lying over the retina. So that is the epiretinal membrane. If you're finding it difficult to correlate clinically, it's always, OCT is one of the most commonly advised investigations in retinal diseases. So it becomes easier to correlate and either diagnose or rule out epiretinal membrane in such a case. So these were the gross clinical features. Now there is a specific staging method that is utilized called gas staging. This is one of the oldest staging methods that we use for macular hole. In fact, it is the oldest method for macular hole staging, and this is based on a slit lamp biomicroscopy examination. This is not using any kind of an instrument. This is exclusively slit lamp, and there are 4 stages across gas classification. So the stage 1 is absolutely no hole present, no defect present. It's sort of a precursor. So the hole is less prominent, as you can see in the right sided image. The center circle, the edges are not well defined. It doesn't seem like a properly formed defect. So there is a precursor lesion to the hole. So such as precursor is called stage 1. There is no separation of the vitreous from the fovea as yet. There is very good attachment between the two. So the tractional forces are yet weak. and there is oblique traction that is seen on OCT. So what do I mean by oblique traction? I'll show you an image a little later in the lecture. So there are two kinds of grade 1. There is a grade 1A, which is a yellow dot, and grade 1B, which is a yellow ring. So the image that you have shown here, it is 1B, because you can see a yellowish ring around the macula. If it was just a single dot that I could see, it was a lesser grade of grade 1A. Grade 1 is usually asymptomatic because the visual defect is very little, and as we've already discussed, the other eye takes care of the binocular vision, so the patient barely notices this, and spontaneous resolution is very common. Almost half the patients will show a kind of spontaneous resolution in a few months. Now coming to stage 2, this is a true defect, but the size of the defect is small. It is about 100 to 300 microns. This becomes symptomatic because now the vision is significantly affected. There is a phenomenon of pseudo-operculum, which means there is a false closing over this macular hole, which may hide the macular hole itself. And there is a condensation of vitreous that you see around the macula. So this condensed vitreous is what is producing the traction. The vitreous is condensing, becoming more dense, and this dense vitreous is producing a dense traction on the macula. Once grade 2 occurs, grade 3 will happen unless you treat the patient, so it is inevitable for progression. The bottom left image, look at the red arrow that I'm showing to you. The red arrow indicates a small line that is in front of the retina. That line is the hyaloid face. So hyaloid face is basically nothing but the interface between vitreous and retina. It is what separates the vitreous from the retina. So when the hyaloid is attached to the retina, it is a normal thing. So as the green arrow points that the hyaloid is getting attached at the retina close to the fovea. So that is a normal finding. It is getting separated elsewhere, but that is okay. We'll take care of that later. First we need to look at whether the fovea has an attachment or not, because the foveal point is the point where maximum visual acuity exists. So here the hyaloid is still attached to the fovea. So this becomes grade 2. Compare this to grade 3. The hyaloid is still attached over here, of course, but the size is larger. It is also called a classic macular hole. Most patients present at this clinical stage because this becomes very symptomatic. 350 to 600 microns in size, significantly larger than grade 2. And along with the hole, there is also a surrounding cuff, a gray line. So if you can see the image, there is a central macular hole just to the right of this image, which in this case it will become nasal. There is a grayish line that you can see. So that gray line or gray cuff is a subretinal fluid. So there is fluid collection within the retina. So this is usually circumferential, sometimes donut shaped if it is an early stage, because the entire subretinal space is not involved, and very often this donut shape is placed inferiorly simply because of gravity. The vision definitely worsens, the patient is severely symptomatic, and a demarcation line very often exists because now the RPE also starts undergoing a degeneration. So the RPE was normally stuck at the back. There was no hole in the RPE, so whatever you were seeing, you were actually seeing the RPE layer because all the photoreceptors above it were destroyed or were taken up by the traction. So this RPE once starts undergoing degeneration, a demarcation line is very often seen. Grade 4, worst possible grade under gas classification. The hyaloid is no longer attached. So you can see in the OCT image. So each color is a different layer. So that is how those layers reflect the ultrasound waves and produce an image. So you can no longer see the hyaloid face that is being attached. It is completely separated. There is no line that is coming and meeting at the fovea. There is no green arrow, no red arrow, nothing. The hyaloid face is completely detached. So this is grade 4. And in this stage, Weiss ring. So Weiss ring is nothing but debris that is present floating in the vitreous. So these produce floaters for the patient. So if the patient of macular hole starts complaining of floaters, start getting conscious about a grade 4 presentation. So that debris could either be retina, that could be vitreous condensation, that could be the epiretinal membrane that is broken off. Anything, it could be anything. It's just basically something in the vitreous that is floating. And perifoveal cystic changes become more prominent in this grade 4. The image shows a sort of a well-like configuration. So this is grade 4, entirely it is going down. The sharp red line that you see at the bottom, that is the RPE layer. So that shows that the RPE is not affected, only the layers above the RPE are all taken up by the vitreous traction. Two terminologies that you need to understand across retinal surgeries and across retina in general. There's vitreomacular adhesion and vitreomacular traction. So vitreomacular adhesion, also called as VMA. So VMA is a precursor to VMT. That is why excessive traction by a VMA will produce a VMT. So vitreomacular adhesion means that there is only a perifoveal separation, but within 3 millimeters of the fovea, there is still attachment between the vitreous and the retina. And no other retinal changes exist in a case of vitreomacular adhesion. Usually VMA is asymptomatic, whereas VMT becomes symptomatic. VMA is classified as small or large depending on whether they fall on what side of 1500 microns, and VMT corresponds to gas stage 1. So if there is VMT, then it is definitely gas stage 1, could be higher but can never be lower. Two types of macular hole that are very often described. There is a full thickness macular hole, which is a self-explanatory term. All the neural layers are affected, and when I say neural, it means that the RPE is not affected, because that is not the neurosensory layer of the retina. And lamellar macular hole means only certain layers are affected. So this depends on the severity. Only a couple of them could be affected. So photoreceptor layers are usually normal in the case of lamellar hole. That is why lamellar hole is less symptomatic compared to a full thickness macular hole. In a full thickness macular hole, there is also going to be subretinal fluid, and that is going to produce the gray cuffing and a rounded edge as seen on the OCT, whereas a lamellar macular hole will not show subretinal fluid, will not show cystic changes or thickening of the retina. Full thickness macular hole can be classified as small, medium or large depending on the size, and lamellar hole does not have a size classification, but it is often considered an aborted macular hole. A full thickness macular hole that was happening, but somewhere along the line either recovery happened or the insult stopped, and the lamellar hole sort of represents a midway formed full thickness macular hole. Operculum is very often seen, which means a small covering over the macular hole, and lamellar, once happens, shows a very low risk for a progression to full thickness macular hole. So that is one of the good prognostic factors. Having a lamellar hole is better than full thickness macular hole. So what do I call a pseudohole? So pseudohole is basically that there is an epiretinal membrane that has formed. For some reason an epiretinal membrane must have formed, and that epiretinal membrane shows an opening at the macula. So that appears like a macular hole, but if you do an OCT, the macula appears to be normal. It is actually the membrane which is showing a depression, which to us seems like there is a hole at the macula. There is also something called stage 0 that is described. So that could either be VMA, that is vitreomacular adhesion in the same eye, or vitreomacular traction in the fellow eye. So such a patient may be considered to have stage 0 according to the gas classification of macular hole. So very high risk to progressing to stage 1 of gas classification. So somewhere along the line we discovered OCT, and we found that OCT was a better investigation to investigate macular hole. So a new classification system was introduced called the IVTS. So IVTS is International Vitreomacular Traction Study. So that utilized OCT investigations as well, and it roughly correlates to the gas classification also. So gas classification stage 0 means there is a vitreomacular adhesion. Grade 1A and 1B, which represent yellow dot and yellow ring, that talks about vitreomacular traction according to IVTS. Grade 2 is a small to medium full thickness hole with vitreomacular traction. Grade 3 is a medium to large with vitreomacular traction. Grade 4 is a medium to large full thickness macular hole without VMT. So now this is a very interesting point. So grade 4, why do we not have vitreomacular traction? Because the hyaloid is completely separated. So remember that image that I showed you, there is no hyaloid attachment in grade 4. The hyaloid has already caused so much traction that now it has completely separated from the retina and produced a full thickness macular hole. That's why grade 4 will not have vitreomacular traction. So how do you diagnose macular hole? It is primarily clinical, and the best modality of investigation is a 90 diopter slit lamp biomicroscopy, not direct ophthalmoscopy, not indirect ophthalmoscopy. The best investigation you can do is a 90 diopter slit lamp biomicroscopy. A particular test called Watzke-Allen test can be utilized. Now this is not specific for macular hole. A lot of other macular diseases will show the test positive. But briefly, what you basically do is you place a small beam of light at the macula, exactly at the macula, by looking through the slit lamp biomicroscope. Once the light is on the macula, either the patient will perceive light if the macular function is normal, or in cases of macular hole, in full thickness macular hole, where you have lost all the photoreceptors, the patient will not perceive any light. So the patient will say that I cannot see any light when you place light on the macula. So such a condition is a central scotoma. So directly placing beam of light on the macula, because there are no photoreceptors, the patient does not perceive light. So this test is called Watzke-Allen test. Again, it is not specific for macular hole. Lot of conditions show, but one of the diagnostic features you can consider in a macular hole patient. And this is again subjective. Certain patients may show it positive, so there are possibilities of false positives and false negatives as well. And it is difficult to diagnose. Macular hole in general is difficult to diagnose in a low grade patient and in a unilateral disease as well. So if you can do fluorescein angiography in such a patient, well and good, you will get something called a window defect. So window defect is again a very non-specific finding. The basic concept of fluorescein angiography is that the choroid is very vascular. It takes up a lot of the fluorescein dye that is present, but the blood retinal barrier does not allow the dye to leak out into the retina. So only the retinal blood vessels and the choroid will show. The underlying retina will be normal. However, if the retina is thinning out, as it is happening in a macular hole, as the photoreceptors are lost, the retina thins out, and because of this thin retina, you can see the underlying choroidal blood vessels, and you can see the choroidal fluorescence. So that is called a window defect. It's like you created a window through the retina, and now you're looking directly at the choroid. Again, a non-specific find. Window defect is seen in a lot of conditions, but if you see it in a case of macular hole, it is one of the diagnostic findings. The most common, the best, and the gold standard investigation is a spectral domain high resolution OCT. In short, OCT. So the OCT shows you three things. It shows you the macular hole itself, it shows you the tractional bands, and it also shows you the epiretinal membrane if it is present. So if you can look at the bottom left image, the red arrow points to the direction of traction. So the tractional pull is happening. You can see the retina is sort of bending to the right side because that is where the pull is more. The hyaloid face is pulling up the retina, and it has taken up the foveal layer. So slowly and slowly, all these layers are going to get involved, and only the red line is going to remain. The red bottom line, the only single thick line that you can see at the bottom. So that is the RPE. Anything ahead of it is going to be taken up by the traction. So this is what I mean by oblique vitreomacular traction. It happens at an angle, it doesn't happen straight. So that is how OCT helps us to catch vitreous traction, vitreomacular traction. The right-sided image is called a raster imaging system. I thought I'll just add this as a side note in OCT. So raster basically means the colored lines that you see are the sections across the macula that I've taken an image. Correspondingly, I get 5 images, 1, 2, 3, 4, 5. And the image number 3 is perhaps missing, or perhaps the bottom image is image 3. So there's 5 images. So 5 line HD raster. So it shows me where exactly is the lesion in relation to the macula. The other thing I can do is a 3D reconstruction. I can take these images and I can produce one 3-dimensional image to macroscopically view the fovea. So that again becomes possible on OCT. So OCT, one of the most beautiful investigations you can do in ophthalmology. A lot of things can be done. For macular hole, it is an essential investigation. How do you treat macular hole? You've diagnosed clinically, you have confirmed it on OCT. How do you treat? First of all, there is no medical line of therapy for macular hole. It is either observe or operate. So when do you observe? You observe it in a gas stage 1. Gas stage 1, you will not want to operate on the patient. And why is that so? Because first of all, 50% patients improve spontaneously over a period of time. Within 6 months, 50% patients are going to improve. So there is absolutely no need to operate if the patient is going to improve. And understand this is a patient who might be aged 60, who might be aged 70, who may already have a lot of other comorbidities. So surgical intervention increases that much risk. So it is better to observe if the patient is at a gas stage 1. And secondly, operating on a gas stage 1 will not prevent development of full thickness macular hole. Remember, intravitreal surgeries is one of the causes of macular hole. So if it is not already present, you may induce a macular hole intraoperatively. So that is again a reason why you would avoid operating in a gas stage 1. And secondly, once the stage becomes stage 2, the success rate jumps up to more than 90%. It is much lesser if you operate on a stage 1, but stage 2 has a more than 90% success rate. So one of the rare diseases where you will wait for the stage 2 increase to operate. Remember, this only applies for going from stage 1 to 2. The same principle does not apply when the patient is at stage 2. You can't say that we'll wait for the patient to go to stage 3 and then operate, but because then the success rate dips down. It is only between stage 1 and stage 2 that observation becomes essential. So, however, you have to operate on the patient. So suppose it is a stage 1 and the visual acuity has decreased for several months, say more than 6 months, without any signs of improvement. Or if it is stage 2 and above, then you have to operate. There is absolutely nothing else you can do. The procedure of choice is a 3-port pars plana vitrectomy. So why do I call it 3-port? I call it 3-port because I actually make 3 ports to access the vitreous. One is the illumination port, the other is the hydration port, and the third is the vitrectomy port, the cutter port. So the port through which I will actually cut the vitreous. So illumination, hydration, and vitrectomy port. So it is also called core vitrectomy because I am removing the vitreous from the core, from the cortex first of all, and secondly close to the fovea. So that is why it is also called core vitrectomy. And I just cut the fibers of the adherent cortex of the vitreous and they are removed with the vitrectomy machine. If an epiretinal membrane is present, that also has to be removed because that is going to affect the vision adversely. An internal limiting membrane, the internal limiting membrane is actually the last layer of the retina that is closest to the vitreous. So if the removal of that is required, a peeling of that is required, that is also considered by several vitreoretinal surgeons. So before peeling, to make sure that nothing else is being removed, only the internal limiting membrane is being removed, I stain the ILM with dilute brilliant blue or indocyanine green. So these are the two commonly used dyes. Dilute brilliant blue is the most commonly utilized. So it stains the ILM. I can peel it off with ease. Do understand that indocyanine green or ICG is also one of the fluorescein investigations that we do. Indocyanine green with light produces an effect called photodynamic effect, which means it alters the characteristics of the tissue through which it runs. So it will alter the tissue characteristics of the retina if too much light is put on it, because it changes the characteristics. One of the few chemical compounds that change the characters of the structures through which it passes. So you have to take care of that. You should make sure that light is not used too often, because understand that you're putting an illumination probe inside the vitreous. Now no longer the light is coming from the operating microscope. You're actually inserting a bulb inside the vitreous to illuminate the retina. So this is what 3-port means. So I'm creating 3 ports. So those small blue, how shall I put it, trocars are utilized to access the vitreous. And you can't just remove the vitreous and leave the vitreous as it is. You have to fill it with something to take the removed vitreous space. So it is either air, either silicone oil, sulfur hexafluoride, or C3F8 gas. And the patient has to be asked to keep his face down for 1 to 7 days so that those gases or those silicone oil remain where they are supposed to be. What complications can occur after a pars plana vitrectomy? So vitreous is essential for the nutrition of the lens, for the crystalline lens. So very often we get a cataract, most commonly a nuclear sclerotic cataract, in more than 50% of the patients within 2 years of surgery. You can induce a retinal tear or a retinal detachment because the retina is very delicate. It is very easy to manipulate and damage the retina intraoperatively, or because of post-operative edema, there occurs a tear or a detachment. And very interestingly, if you perform a macular hole surgery and after that you perform a YAG capsulotomy, which is basically made to open up a small aperture inside the posterior capsular opacification, secondary cataract, the macular hole can reopen, because we still don't know how it happens, but the laser is supposed to produce some amount of edema which is going to damage the macula again. So that complication needs to be taken care of if it happens. Newer modalities of treatment are available, such as intravitreal ocriplasmin, which is basically an injection, or an inverted ILM flap mechanism, which is often used for gas staging 4. So just names I thought you should remember. Very often they ask MCQs on this. What am I expecting for a patient to improve or not improve? So spontaneous closure happens in 50% of the cases of stage 1, as we already discussed. Stage 2 shows a very little spontaneous closure of about 2 to 4% only. So unless you operate a patient of stage 2 and above, the prognosis remains very poor. The end goal is seen on an OCT, which is to be monitored 2 to 4 weeks after surgery, and after that every once a week for the next couple of months. And the end goal is the reapproximation of retinal tissue, which is covering the defect. So exactly this is what you want. So again, a black and white image, most likely a raster imaging system. So this is what you want to see after a macular hole surgery. So this was a gas 4 staging macular hole which was operated with a pars plana vitrectomy and an epiretinal membrane peeling. So the preoperative OCT would have shown a full thickness macular hole, but post-operatively, this was 6 weeks after surgery, a very beautifully approximated retina and the foveal pit has been restored. So this is what you want to achieve. This is the perfect ideal end goal that every macular hole patient surgeries should show. That takes care of macular hole. Just a small announcement here. We will be coming up with a live lecture shortly. We'll be discussing some of the doubts that you may have in ophthalmology across the entire subject, and also talk to you about the current situation regarding academics in ophthalmology. So we'll announce that shortly. We'll have a live lecture with an interaction with you guys soon. As always, thanks for watching. Stay safe. Good day.